I next want to turn our attention to, well, a set of general cleanup, let's call them miscellaneous issues here in physician-patient relationship. The core to this section I've just gone over with you when I did the rules, but there are some terms and some other issues that do show up in the exam I want to spend a moment commenting to about you so you understand what they are when you see them. First, I want to make sure you understand by the terms that are listed before you here. These terms are sometimes used in questions, or sometimes these are options you're supposed to pick as an answer to a question. What do we mean by an open-ended question? An open-ended question is one where you're opening up the floor to have the patient talk. These are not ones that can be answered by a few words, a yes or no, a head nod. These are ones that require sentences and stories out of patients to tell you something. It's usually a pretty good idea to begin your clinical encounter with an open-ended question. Tell me what brings you here today. You want to open the floor so you can hear in their words what they have to say. Closed-ended questions. Closed-ended questions are ones where you're seeking specific information. They're usually ones answered by yes, no, a head nod, or just a very few words. You want to avoid beginning with closed-ended questions, but some of you think closed-ended questions are always bad, and that's simply not the case. If you need a key piece of information in order to understand what you need for the differential, then ask for it. You want to make sure you have the piece of information you need. If the person doesn't volunteer, a closed-ended question where you frame it, they say yes or no, gives you that crucial piece of information. Leading questions, of course, are what you always want to avoid. A leading question suggests, in the way the question is presented, in the word choice and the tone and the nonverbals, what the answer ought to be. Leading questions are asked when you've decided and you're trying to get people to only give you information to confirm what you're already thinking. This is bad medicine, folks. This is you getting information twisted to confirm what you have as a preconception, not getting the information you need to find out what's really before you. A leading question might be something like, so that pain you see in your back, is that a sharp throbbing pain that comes and goes in the morning and is better in the afternoon? Well, patients, when you're that detailed, tend to say yes because they like to be able to agree with you. Confrontation. Confrontation is bringing to the patient's awareness some aspect of their appearance or demeanor. Confrontation is always felt as hostile. Now please note, it's not usually done hostilely, but it's usually taken that way. So confrontation is something as simple as, I see you have a yellow shirt on today. That, by this definition, is confrontation, bringing to their attention some aspect of their appearance or demeanor. You use this confrontation when you want to engage them on an issue, but I want you to be aware, whenever you do this, there's always the implied sense of some hostility underneath. If there's something you think really needs to be discussed and they are not discussing it, confrontation is the way to bring it up, but be aware you're engaging in risky behavior. Facilitation is the opposite of risky behavior. Facilitation is getting the person to tell you more. After the open-ended question, you want to get them to keep talking about it. You do that, as I'm doing now, with nonverbals. You do that with head nods, interest. You also do that by verbally saying, that's interesting, tell me more, I'd like to have you say more about that. You're trying to get them to give you the information you're looking for. Redirection. Redirection is taking a question in and sending it someplace else. Redirection might be they ask you a question and you say, well, I think that's something we should check with, and then you name somebody else who has that information. And finally, a direct question. A direct question is one where you ask and you expect a direct answer. When patients ask you direct questions, you will give direct answers. This is something that occurs when you have a good, solid relationship. People understand the context of the exchange. I'm going through these terms not so much because you're going to be tested on what they are, that's considered too simplistic, but I want you to understand what these options are as you're thinking about answers for the exam questions. I next want to take a moment and just make you familiar with a commonly cited concept, the sick role. The sick role is the social role that people take in when they have some health problem. It's the way they reorient their relationships with other people because of the health problem they perceive themselves as having. The sick role has two rights and two obligations. Now, we like people in the sick role when they have something actually wrong. When people are in the sick role when nothing's actually wrong, then we think they're conning us or malingering. The two rights you have are, one, you have the right to be exempt from normal responsibilities. When I'm sick, I don't go to work. When I'm sick, I don't have to take that exam. Normal responsibilities don't apply to me. Something's wrong. This is an exception. And two, you're not to blame for your illness. You come in with a cold, we don't say, you did that to yourself. We give you sympathy. We treat you as if this is something that just occurred. Please note, even if we know causally that you might have done something to make this happen, a patient with lung cancer who smoked like a chimney for years, we don't walk in and talk to the patient like you did this. We use the social fiction of this is just an event that happened. In order to gain those two rights, you have two obligations. The first obligation is to get well. The reason why you're exempt from normal responsibilities is you're supposed to be healing, getting better. If I say, I'm sick, I'm not going to work, and I go bowling, that violates the sick role, because going bowling is not going to be what will facilitate my healing. I also want to point out that the sick role only applies, therefore, to acute conditions. If I have someone with a long-term chronic condition, something they will always have, well, then they're never really going to get well in that sense. Better, yes. And you can talk about them taking time to improve their functioning. I'll accept that, but they're not really going to get well. And finally, to be in the sick role, you're supposed to show that you're trying to get well by seeking competent help. You, at the very least, might go to the drugstore, talk to the pharmacist, try to get information, or we expect you at this point to go to see a doctor or some other healthcare professional. Remember back when you were in school and you were out more than 3 days, you needed a doctor's note before you came back into school? Well, that's basically the bureaucratic application of the sick role. You had to show that you actually got competent help to try to get you well. The sick role, again, is the social role people take on, the exception to normal day-to-day life they take on because something's wrong with them. Two rights. You're not to be blamed, and you're exempt from normal responsibilities, two duties. You're supposed to get well, and you're supposed to seek competent help. I next want to take a moment and talk with you about why we care so much about the good relationship we have with the patient. We've discovered that lack of rapport, lack of that good relationship, is absolutely the chief reason why terminally ill patients reject medical advice and go off and do things of their own. Whenever patients are not cooperative, whenever they're not adhering to treatment, we've discovered that the number one reason seems to be physician insensitivity. Now, please understand this is perceived insensitivity. It's how the patient sees the doctor. They think the doctor is, in some sense, uncaring, and that matters more to them than all the technical skill and proficiency. If you give more information, they get better sooner. For some reason, knowing makes it hurt less. For some reason, having the information makes it so you simply can deal better with what it is that's happening. Now, just on a simple level, if you ever have a Band-Aid on like a hairy part of your anatomy, and if I came up and told you I was going to take the Band-Aid off, that's one discussion. Or if I just sort of snuck up on you, ripped it off when you weren't looking, well, that causes more distress. The surprise, the not knowing, the anxiety simply causes more distress. Good rapport fosters adherence, gets patients to do what they should. And here's a real good issue. You get sued less. There are fewer malpractice suits if there's good rapport. Because if something goes wrong, I should say when something goes wrong, they can be dealt with in the context of the relationship. So let's talk about how we get the best adherence. Let's talk about some simple bullet point suggestions for things to do that research has told us improve adherence. You want to give patients the information they need, but you don't want to overload them with a lot of technical things they don't need. You want to explain complexity when it's there, but not simply overload the patient with the complexity. You should pay careful attention the whole time you're talking to the patient's affective state, because once you get affectively engaged, aroused at a certain level, you simply stop listening. Anxiety makes it hard to listen. If you want to recommend a treatment, you don't just recommend, you explain why. You talk about the details of what's good and why this is good, not just in general, but for them in particular, because remember, that's what the patient cares about. And then we strongly suggest you stress the problems with non-adherence. If you don't do this, here's what will happen. Here are the negatives that are in place. You want to stress the effectiveness of the regimen. You don't want to lie, you don't want to inflate. We want to make sure people understand that this is not just something chosen, it's something chosen because it has proven benefit. Should you give instructions orally or in writing? Well, the right answer then, of course, is both. Because it turns out people understand what you say more, but people value more what's in writing. And so if you want them to think what you're saying is significant, you want to do it both ways. Contact is crucial. You don't simply have an occasion where you lay it out and walk away. Periodic checkups, calling. In this day, email is a wonderful device used increasingly to get adherence. The less you ask the patient to do, the more likely they are to do it. Some people think if you give a patient something to do every day, they're more likely to remember. It turns out the opposite is true. The less you ask. And so a pill you take twice a day is better than a pill you take 4 times a day. A pill you take every other day is better than a pill you have to take every day. Research suggests in a pretty straight line relationship, the less you ask, the more likely they are to be adherent. Finally, I want to conclude our conversation by focusing on the so-called health belief model. The health belief model is probably the most researched and talked about model in terms of how to get people to be adherent, how to get people to do preventive medicine behaviors. This model has had a tremendous amount of research done on it. It is not the panacea that it once was considered. That is, the health belief model is not the be-all and end-all, but you should be familiar with it because it does pop up as the background to questions we're asking you what the right thing is to do. First, the health belief model begins with the idea that whether or not you're going to be adherent is a function of the threat you feel. If you don't think there's any threat, then why should you listen, right? I want to remind you that it's moderate threat that is best. If you scare them, then they stop listening. If you don't get their attention so they feel any threat, they don't listen at all. We have, once again, that curvilinear relationship. We're mid-range. And you really want to provide a sense of threat, but with a quick solution. This is, I remind you, how, well, we sell people things all the time. This is how we get people to use deodorant. Raise your hand if you're sure. As long as that deodorant's in there, then the threat's gone. You want to use the mouthwash before you kiss your beloved in the morning. There's the threat and there's the solution. You want to do the two together. So how do you get people to have a sense of the threat? Well, it's all about 2 issues, seriousness and susceptibility. Seriousness, they have to understand the disease and understand this is something that is serious, that is, requires their attention, their consequences if it's unaddressed. Secondly, though, they have to understand they personally are susceptible. If I know there's some horrible disease out there, but I think it's for other people, not for me, there's no basis for me to act. Patients have to understand, 1, the disease, but 2, their personal vulnerability to the disease. Once people know that it's serious, that they personally are susceptible, now you have the motivation you need to get them to act. But if you're going to get them to actually do the action, you have to make sure external barriers are also removed. External barriers can be things like, well, you don't have the finance, you don't have the insurance for medication or for physician care. You don't have access. You may live a place where there's not a lot of physicians around, and these external barriers are crucial. If you have a clear sense of something being important, you being susceptible, but you don't have the resources to deal with it, then you tend to just suppress it, push it down, and don't deal with it. The point of this discussion is just to remind you one last time, adherence is your responsibility. Getting patients to do what they're supposed to is not a matter of you telling them, it's a matter of you helping them. You're supposed to break it down so they understand, make sure they clearly understand they personally are vulnerable, and work with them to overcome the barriers that might otherwise stop the adherence from happening.